tube them, right? But merely seeing swelling here to the lips and the nose, a little bit of time to do a more thorough assessment. What do they look like inside? Are they mentating? How do they sound overall? Does this make sense? So being able to pump the brakes just a little bit before reflexively intubating merely because you hear COPD. And I'll say, not necessarily you guys, but inexperienced clinicians, I'll see this in ED settings sometimes, the pulse ox is 91%. By definition, this patient is hypoxic. Let's throw in some capnography. Well, crap, their CO2 is 52. This is a hypercapnic, hypoxic patient. Dear God, let's tube them now. Except for a COPD, that's probably baseline for them. Does that make sense? So again, I'm not saying never intubate COPDers. I'm saying with this profile, intubating them automatically, because it might be a one-way tube or give other problems. Does it make sense? So slow down unless they're already having distress. There's a little bit of time that's just fine for watchful waiting for those patients. Okay? And again, for the short transit times that we have here, 15 minutes to an hour and 15, etc. If they need that tube later, the ED is going to be fine doing that wherever that needs to happen. Okay? Let's break there with our aid and come back. I have, what's this? 2:25-ish. Come back 2:35. We'll come back in 10 minutes or so. 2:35, if you please.
How you doing? Yeah. Okay. I'm actually going to run right here, so you can do the recommendation.
So now that both of you
You gave me my
yeah, I got it. Oh, I didn't think so.
Granola bar and banana.
I did a transporter rock.
Is that your first one? What are you going to take?
Yeah. Whenever you want to go.
That's a little, because you know, sometimes I take my. Yeah, right. Never mind. That's it. I just self-medicate. Yeah.
Sorry, I didn't like doing the
Oh, yeah,
transporter Roxy, but then found out my laptop wasn't working, so I had to go back and switch it out. I gave it to Tammy, who's not in that truck. I had to do the paper form, so I could do all those. I learned how to do that.
Yeah.
And I didn't know where I was going into law enforcement. That's where GPS took me.
Oh, what did you put in?
Well, when I was scrolling through, I clicked the wrong thing.
Oh, okay.
And then when I got there, this is back. I was close. Just right around the corner.
Thanks, sir. I was actually getting dressed. You knew that you found your food out right here.
Look like a receipt.
It is.
She told me it was F, was it FCT or F?
FTCC.
And I put in training center. General.
Yes, I forgot. I am, because these plugs right here don't work. And my cord didn't reach the wall.
didn't want to bother that way, because it makes sense.
You can only do that
Like-
with this thing.
Daisy chain, years together for
Yeah,
backwards.
she was like, well, she left to go teach, and she said, I'm gonna just close my computer. I said, no, I'm using your computer, turn it on. Just leave it.
I'm looking for somebody to fill my pool, the fire department will fill it. And I don't want to pay PWC. So, but I might have
Friends with the
to.
fire department.
I did.
I wouldn't have nice to do a uniform and all that. I was sick for the smoke election.
I know,
But
you
they
go upstairs,
said-
you can bring.
But they said they were cooking, you know, they don't want my food.
You're like, can I stay
That's
in
it.
your house?
See, that's when you just find out how many
He
are
said,
here, just bring them like
he
this.
said that, but I had a friend to kind of do it last time. And his friend was in here, and they were doing it.
So Bobby, what's your,
Big fish in the fire, taking the gold color.
Well,
It's
you
big.
know, that's the, I, being stupid, thought that
PhD,
fire hydrants were fire departments. But obviously they're controlled by PWC. Well, see, I asked him, they said, well, you said, you could hook a hose to it. Because I said, we hold the water on the truck. It's like, bring your hose and got hydrants. I got a hydrant right down the road. And he's like, no, but you could have someone that only have the hose in the road. You can't do that. Well, then, we'll give you suggestions.
If I, you don't know, it'd be cheaper to just have.
Yeah, that's a-
it's probably highway over.
I'm sure fire departments are in all hospitals.
Well, I hope we wouldn't be
You know,
safe.
if you swap the right hoses, I think when you drive down the road.
Yeah.
Yes.
Yeah. Just go by, just scoop it up.
That'd be like saying
Or I can run out there on my Grace Creek, you know, where they have all them bottles of gallons of water that they don't put in their house and just start confiscating them. And just-
I think he does a fantastic job, absolutely.
I'm desperate measures.
That'd be like me trying to talk to combat. It would be the same thing. You know, because I had, first of all, I've never been in the military, and I've never been in combat. So there's no way for me to relate to that person.
That's the goal.
Yeah, there's hoses. What is it, someone for $50 tomorrow?
We'll see.
I mean, hell, you already know 2/3 of the people that work.
It's got to
That's
be,
crazy
it's
anyway.
got to be a law.
So that program that,
I remember.
30%. Based on the 70 or so.
That's way better than. Right.
I'm down.
So, and it's something like nationwide, we say close to 1%. And moisture measures. 8% of those will resolve their own, without going out of the way. It's a much smaller amount of
Well, they actually have schools plus what delivers the water. Now, that's pretty good.
Yeah.
See, this is 25 of those.
It's got at least a block.
So it's like
Yeah, no, I'm trying to figure out where
they don't always focus on.
to get one. Water, down the street. That's where it was. There you go.
It's the water, you take something down, and you flush it out.
Yeah, well, I think it's already done.
I mean, it's just stash. It's dirty, really, you're gonna hold
No,
these
right here.
maybe salt.
Clinical time.
No, because it can't function.
You can always use your neighbors, though.
My husband suggests that.
That's what I'm saying.
You know what I mean?
Yes, walk this side, walk this side.
Oh, we're glad
He said,
that they're
you get 2 weeks free swimming.
And then you gotta drop a line down there, man, you guys see what I'm doing with me? Freaking high, you know, just like.
Yeah, we're gonna see. You want to, I can write you a page right now, something that's really great.
Yeah, see, I am horrible. I am horrible at promoting. I can promote you all day long. I can talk about you and all of the qualities, blah, blah, blah. I can write a book. Like 2 sentences.
Sorry, Kelly, but you're right.
That's terrible.
You're right.
It's hard for me to sell
I can
meat.
pull the research figure out what else is competitors, right? Anything else?
I'm sure narcissists in the.
This, when I was doing my degree, a lot of
The
times,
driving portion now?
I would write a paper the day it was due.
Oh, yeah.
Because I could do the research, write the paper, and like 2.5 hours.
Yeah, me too.
They're
I
actually,
can pull something out real
all
quick.
that, a lot of homes out there. Yeah, and they're practicing right now. They have somebody driving the,
Yeah, well, I'm sure
started
that
that like right
might take
after
months.
my class
It
there.
depends on PWC.
The actual writing was called research.
I'm gonna call them and ask them. I know that they should charge this on their property because it's not going back down. Well, that should be half the cost there. Well,
So last shift we had medic six. Last shift we had medic six.
I'll call them and see what they're doing. That was what I'm paying, so exactly how many. Which I'm not even gonna fill it all the way.
Two cameras, one here, and one here, and then one right at the bridge. Like this.
Yeah, it was by the end of the 70s.
These are almost good. Almost good. It's like the difference, it's like what had happened, like one of those like pickled sausages
Now, see, I
and
can.
beef jerky. I had a baby.
I mean, I'm not a good.
Vinegary, smoky, but not quite juicy, but not quite dry.
There's
So it was
one
like-
around here.
They didn't make it. Yeah, man, sure is. I was like, no, man, that's a beef.
Let's see, you have reference page.
I got one the other day. Got a wild hair, and I got me one of those Savage
Regular Japanese.
Slim Jims.
Yeah, big one.
It's like a yard of
Sushi and then there.
Slim Jim, and it's like
But it's not
that
like
thick. I ate off that thing for a week. I watched a buddy of mine eat one in one sitting. I was like, man.
So we have
Hungry.
Did they get?
What was your blood pressure when you were done?
Enough with your next question. You said an average.
I see bright lights, but I'm in the dark room. What the heck? You know, I'm gonna say this.
Yeah.
This is all the school. Burn, like, education we get. Yeah, that's not gonna be entertaining. So moving on.
There's one down
Just
there.
to know where it hurts.
I don't like this.
And that's not it.
Yeah, for me, it's like if it's not fresh, like, you won't catch me. Good sushi place.
It was like right.
Okay, friends, let us carry on. So thesis so far is that we've rolled up with emergent care for a scene response. And we've been careful not to be distracted by the burn. We've thought deeply about what are the life-threatening injuries in our primary. We've looked for any killer bleeds that might temporarily trump airway. If there's airway loss as a concern, we've secured that airway up to and including an ET tube or whatever else is needed to make sure they have patency of the airway. Now we move up to this part, because again, just because you have an airway doesn't mean that they're breathing or that they're breathing well. So a few thoughts. We said before, assuming you have a patent airway, what else can you do to improve oxygenation? And you mentioned CPAP, or broadly positive pressure ventilation. The other, increasing the concentration of oxygen, i.e. FiO2, supplemental oxygen, whatever. I'll just throw some thoughts out there since we mentioned, or you guys mentioned COVID patients as an example. I try to get fancy with my slides and include hot link resources. So when you get Pam and Leslie both have digital versions of these that they can share with your teams, but that opens up to a lovely resource article that's true broadly for critically ill patients. I think maybe it's trickled down. We know for post-MI, so post-heart attack patients, that the metadata says hyperoxygenating actually leads to worse outcomes. Right? And you guys, this is kind of in the water. It's trickled down. People broadly know that post-MI, more oxygen than you need can actually lead to worse outcomes, higher mortality, etc. The metadata says it's true for COVID patients too, that if you're aiming for SATs of 98 to 100%, you're probably going to break the patient and lead to worse outcomes. Even early data from Wuhan back that up. SATs in the mid-90s, just fine. Turns out metadata says broadly true for critically ill patients of any stripe, including trauma patients. Too much oxygen can also be a bad thing. Does this make sense? I'm hoping this is trickled down, etc. So have reasonable targets. Another way to say this is you don't necessarily need to give supplemental oxygen to every patient all the time, period, full stop. Have a reason to do it. Right? What is your indication for it? How do you know they need it? And then how do you know if it's effective? I.e., can you track particular targets? Low to mid-90s can be just fine. You don't need 100% SAT. This is true, again, post-MI, COVID, and true broadly for burn patients as well, unless you have a specific reason for it, what's your target. So that's my parenthetical aside about supplemental oxygen. It's great, but you can have too much of a good thing. If I look over here, what do you guys think about airway patency? How have we done so far to address airway? Because we're on breathing ventilation now, but how have we done in terms of airway? You're shaking your head no. Tell me
If
what
you've got a
you're
non-rebreather
thinking.
breather on, I'm guessing it's been identified that he has a patent airway.
Okay, so hopefully they've done the right things. We just went with non-rebreather. We have the nasal trumpet there. And this is where I want to, like, whoever this is, I want to, like, bless their heart. It's not actually over the, you know. And this is kind of the, you know, this is maybe, it's also on room air, right? Like not hooked up to oxygen or whatever. So we know they've taken some steps. And again, I don't have a patient in front of me to assess, but based solely on the burns, I mean, this is some at least deep partial thickness. It looks circumferential around the neck and maybe even the chest as well. So some initial, now again, I don't know who the provider was. Maybe this was someone who does not have intubation privileges or whatever, right? The scope, not my slide or not my picture.
Maybe his ears were just full and that was the best way.
Right. So we got lots of options here, although, again, the things that are worrisome, the full extent and the fact that the burn also includes the neck and could potentially partially circumferential. So if I'm doing well right now, okay, but I would have a low threshold for saying that we may need something more definitive. Does the rationale make sense? that this alone might not be sufficient based solely on what I see here, okay? Because this idea of a burn being circumferential around the neck, that could include airway, maybe also impair circulation. Turns out in this case, once they reached the hospital, they thought, man, he's got burns all over his neck and chest. He's going to need something definitive. This is also going to be in the hospital for a while. So they went ahead and placed a trach. They did a tracheostomy. I'm not asking you to do that pre-hospital, but they got the tracheostomy. So let's say that we've definitely secured upper airway, okay? But we're still not out of the woods from the breathing and ventilation perspective, okay? The patient is on the ventilator, but even for you as you're bagging the patient, let's say that over the course of your 30 minutes with the patient, you notice that they are progressively more difficult to bag. Okay. What are your thoughts? As it's harder and harder to squeeze your breath in with your ambu bag.
And there's a
Swelling on the chest.
Okay, so there's a restriction, obstruction for some reason. Okay, and I see one theory offered was the restriction around the chest, the burn itself. Okay, and depending on what else has happened to this patient, if this is 12, 18 hours later and they've gotten a boatload of fluid, maybe this is pulmonary edema on top of this, I don't know. But if this is what we see, the concern here is, again, the full thickness, circumferential or partially circumferential burns on the torso. What you worry about is a tourniquet effect, okay? In which case the advanced airway doesn't solve your problem. I cannot squeeze air into when there's no give, so to speak, okay? The good news is, in the first minutes to a few hours post-injury, this is not a concern. It's progressive and it takes time, so I'm not asking you to do anything, do an espirotomy in the back of an ambulance in the first hour, but what we're worried about is progressive development. So if you're already having difficulties moving air despite patent airway, you immediately make sure that's a concern, because we mentioned espirotomies. That's one. The torso is one place we look for circumferential restrictions to blood flow. Extremities are the other, okay? So what's done in an escarotomy is a small and tiny incision that's made along the burn wound from good skin to good skin. And the idea, it sounds goofy, I think of ballpark franks in the microwave. A medical director, he says it's like, for him, he thinks of popping cans of biscuits. It's kind of same thing. You're relieving pressure. And we're relieving pressure to restore perfusion. Okay? Now, for the torso, because this is pictures of the extremities, for torso, because again, I'm not asking you guys to do escarotomies, but if I do have circumferential impairment of mobility, what are the clinical signs? What are the things that would cause you to be worried about it and communicate that at handoff, like bringing that right up at the top of your concerns?
You mentioned the effort it took to bag.
Yeah, right. So, and this could show up as one of two flavors. Either the same amount of pressure buys me less chest rise, so same pressure buys less volume, or said differently, to get the same amount of chest rise, I have to use a lot higher pressures. That inverse relationship of volumes to pressures. Does that make sense? So that tends to be one of the early signs. Now you guys have mentioned this a couple of times, if I'm also monitoring this patient with capnography, okay, even before they have the advanced airway, but of course we can do capnography even if they don't have an ET tube. What do you anticipate might happen with their capnography over time if my chest excursion becomes progressively diminished? Hazard a guess. What do you think you might see with capnography?
Maybe retaining CO2?
Yeah, they would turn into a CO2 retainer. Now, since I have some maybe newer practitioners, I'll offer this as an easy way in my brain. If you want to eliminate CO2, you have to move air. With the technical term for that from respiratory therapy, you speak, it's minute ventilation. How much air is moving through their lungs over a minute. okay? I'll say minute ventilation is to the lungs, what cardiac output is to the heart. Okay, minute ventilation is to the lungs, what cardiac output is to the heart. What's the formula for cardiac output? Stroke volume times heart rate, right? Stroke volume times heart rate. How much each contraction and how many contractions. Multiply those together, that's cardiac output. Minute ventilation, it's the same thing, it's just for the lungs. Okay? Not stroke volume, but tidal volume, how much in a breath, and how many breaths. Well, that's respiratory rate, so it's the same, just different organ, right? How much air going through the lungs in a minute, how much blood moving through the heart in a minute. And if you want to get rid of more CO2, you got to move more air through, which means either bigger breaths or more breaths, or both, right? So if you're not able to get those breaths, or getting smaller and smaller and smaller, we're expecting capnography to rise. So often, that's another early sign that the clinician thinks something's up here, okay? I'm seeing less chest excursion and CO2 is going up and up and up, okay? 30, 40, 50, whatever, okay? What else might catch your attention on this? What else lives in the thoracic cavity in the torso, besides the lungs? The heart, it's a short list of, right? Short list there, right? Heart and lungs. How might increased pressure in the torso, in the thoracic cavity, influence cardiac output or hemodynamics?
It's going to decrease the speed.
Yeah, cardiac output will go down for a variety of reasons. If I'm increasing pressure in the chest, then blood's having a hard time returning via cava, squish, therefore stroke volume goes down. Now what about from above? If it's high pressure in the chest, how about blood draining from above? The blood draining from the brain coming down into a high pressure system. It doesn't want to go, right? We have a name for that, it's JVD, right? Jugular vein distension, because it doesn't want to flow down. Another thing that can be scary, particularly in polytrauma, is that increased intrathoracic pressure may be transmitted and turned into increased intracranial pressures, which is bad news in a polytrauma. Does this make sense? Let's take it one step further, because we know to look for increased intrathoracic pressure. Y'all all have thought of, or been probably taught to have a healthy respect for compartment syndrome for extremities, right? Arms and legs. But there's one other place people tend not to look. It's the low person on the totem pole. Nobody thinks of it until too late. And that's the other ACS. Well, who's the first ACS? Acute coronary syndrome, STEMI, non-STEMI, angina, all that. Who's the other less sexy ACS? That's abdominal compartment syndrome. Abdominal compartment syndrome, also known as intra-abdominal hypertension. Who's at risk for increased pressures in the abdomen? A lot of people, a lot of patients. It could be the gunshot wound and there's a belly bleed. It could be the raging sepsis from a peritonitis. It could be your classic liver failure medicine patient with that third trimester ascites belly, right? They're tight as a tick. It could be your burn patient after your 12th liter of LR, whatever, when they're over-resuscitated and tight as a tick, to use that technical term. This makes sense? So imagine what happens if the abdominal cavity becomes pressurized because there's fluid coming in and can't get out, and pressure goes up and up and up. How do you tend to notice this is becoming a problem? Well, yeah, so it might become distended. Okay, hopefully you're looking. And what happens beyond looking, you actually touch, it'll feel tight, right? Okay, so your physical assessment, absolutely. Looks swollen, feels tight. Often, and the literature's pretty clear, people don't pick up on it until much later in the game, after they're already symptomatic. What are the symptoms that catch people's attention? If my belly's tight, often, where's it going to go? It's going to push up on the diaphragm. And the thing that gets my attention is the increased intrathoracic pressure. and I missed the increased abdominal pressure. Why? Heart, brain, lungs, I pay attention to the Holy Trinity, but I forget about the second-class citizens who live down here. Does this make sense? So I don't notice it till hours after the fact, after I've already had hypoperfusion to my gut, to my kidneys, et cetera, et cetera. Does this make sense? So if they look distended, feel tight, take that seriously, and that small changes to capnography, small changes to blood pressure, heart rate, pay attention to that, because you may be on the front end of abdominal compartment syndrome, not just for burns, but for many types of patients, and able to act before then. Okay, all right. So we talked about ways to figure out the torso is having compartment problems. What are your signs that an extremity is having compartment problems?
Loss of circulation.
So yeah, so loss of circulation, and how would you know? I agree, but how would that show up clinically?
Just
Gap
gap refill.
So gap refill, so it goes from brisk to sluggish, perhaps.
Discoloration.
Yeah, discoloration, i.e. paler than it was, or pale compared to the opposite extremity, perhaps. And you said something else.
Decreased pulse.
Yeah, okay. So the quality of the pulse goes from, strong to weak and thready, for example. You kind of cluster those into, they're billed sometimes as the 5 Ps. I always come up with like 7 or 8 Ps, a lot of different Ps. You guys have touched on some of them. Let's agree that loss of pulse outright is a very late sign. Wouldn't it be great to figure out I have a problem before the pulse is gone entirely? So what are some of the other Ps? Well, the paleness, that's pallor, right? Pain. And the thing about this pain, that morphine is not touching it. It is out of proportion to what you see, right? It's just unrelieved by the opioids. It's not helping at all, okay? And it feels, they'll sometimes can even verbalize, it feels like pressure, okay? What are some of the other Ps in this cluster? Paresthesia, okay? What is that?
Numbness and tingling.
Yeah, the numbness, tingling, pins and needles feeling. I'll give you a way to remember that, because I like that one because it tends to be one of the earlier signs. Okay, whereas loss of pulse is a late sign, the numbness, tingling tends to be earlier. Has anybody ever sat on the throne too long to pinch a loaf? Getting all right? And if you say that's never happened to you, you're a liar, all right? But here's more P's for you, because you're sitting there too long and you get up with that pins and needles. Had a paramedic out of Elizabeth City tell me, oh, that's called the pooping polio. That's walk out. That's 2 more P's. Right? So paresthesia, your sensory neurons are poorly perfused. Ergo, numbness, tingling, pins and needles. What about motor neurons if they're affected?
Like
Yeah, like emotion. Paralysis, another P, right? Not paresthesia, but paralysis. Tends to be later than the paresthesia. So those are all findings. And again, you guys are not asked to slice and dice, but if you're having progressive diminished pulses, progressive lengthening of the cap refill, and that's not attributable to global circulation problem. I'm not saying they're bleeding out and that's why the pulse is going down. The pulses are great on their legs, but my God, down the left radial, downstream of that circumferential forearm burn, I'm seeing changes here. Then that's where you start thinking compartment syndrome. Okay? So again, think holistically about those, but please catch it before we're fully neck deep in the pulselessness part. Okay? All right. So notice, we've talked about ABCs, and I still haven't talked about the size of the burn yet, right? Reason for that, again, I'll stress, emergently, life and limb, there are more things that I'm concerned with besides using a Parkland formula to come up with, whatever, or having a percentage to talk about the burn. So these guidelines have been out since around, I want to say 2016 or so. These were published as a response to the fact that most of the time, people who are treated initially with some attempt at the Parkland, the formula is wildly wrong, or the burn map is wildly wrong. So the attempt here is, let's make it even simpler for the initial, again, this is primary, the initial response, okay? And it's just basically a 3-tiered formula. Age of the patient, okay? So garden variety adults, get some access and just get something going. Now this says LR. We do prefer LR, but if what you have is normal saline on the truck, then it's better than hypovolemia. You give them what you got, so that's normal saline for right now, although Leslie says we're transitioning to LR. Okay, woo-hoo, right? For the first liter, maybe the difference may be relatively minor, but by the 5th, 6th liter, in big resuscitations, whether burn or polytrauma or otherwise, there do start to become different outcomes in mortality related to the composition. You start having problems with hyperchloremia, metabolic acidosis, et cetera, et cetera. I'll put a plug in here. There's a lovely landmark research study, not mine, et cetera, but it's called Basics, and it's balanced solutions versus sodium fluoride, et cetera. It attempts to answer some really great questions of which fluid is best, how fast should you infuse, boluses versus controlled rate, etc. It's pretty critical stuff in terms of driving how we do what we do. I'll encourage you to take a peek at it. You can just search Basics. I think I pulled it up, or at least in PubMed, whatever. Encourage you to take a look, just so you can be an informed practitioner. But yeah, Basics, and they spell it in a wonky way, but it's looking at critically ill patients. It's a multi-center randomized trial. It's not just burn patients. They were doing, pairing of